Here is a causal diagram of a randomized controlled trial. We have allocation, which is a coin flip, which decides allocation to treatment or comparator. T, treatment, is access to either treatment or comparator. D is the disease or the outcome measured at follow-up. And crucially, A is unconfounded with D. And it's guaranteed to be so if A is completely random. If nothing can influence A, then there's no backdoor between A and D. And we know that they're going to be unconfounded. There may be confounding between actually adhering to treatment and the disease. And that is why in a randomized controlled trial, we care about the effects of allocation on disease. We're going to talk more about that later. But this is the general idea of a randomized controlled trial, that allocation to a specific treatment is random, and therefore there can be no backdoor between allocation and the disease or outcome. So, how do we randomize? Well, you could do individual randomization, just flip a coin for each participant. It works fine and is a good way of randomizing participants in large trials. You can use blocked randomization, which ensures that each arm gets the same number of participants. Can also ensure that each site, if you have multiple sites recruiting participants, that they get the same number to each arm. Make sure that you use random block sizes so that you don't make allocation predictable when using blocked randomization. You can use stratified randomization, which ensures that some characteristic is equally distributed. For instance, if you want to have retired and non-retired and make sure that that's balanced between groups, you can use stratified randomization. It's useful in small sample sizes and for low prevalence characteristics. Always, don't forget to adjust for these variables in analysis. They need to be adjusted for in your analysis if you use stratified randomization. Cluster randomization, if it's not actually possible to randomize individuals, then you can use cluster randomization. So you might randomize communities or villages or schools. Analysis can then be at the cluster level or at the individual level. There are some considerations you need to take when using cluster randomization. So consult somebody who's used to using cluster randomization. Randomization needs to be random. Now that is sometimes overlooked actually. You need to use a computer or some other method, for instance dice or flipping a coin, so that you guarantee no confounding. So I'm going to scroll back up here again. If you use anything that could subvert the random process, something that could make allocation here non-random, then you risk confounding between A and D. So it has to be random. Don't use information like day of the week. For instance, on Mondays we're going to put people in the control group, on Wednesdays we're going to put them in the treatment group, and so on. Don't do that, because then it's not random. Don't use any patient numbers, day of birth. Don't use alternating. So that's a common pitfall. There you go, oh, I'm just going to take first one treatment, then one comparator, then one treatment, then one comparator. That's not random and can break the whole idea of a randomized control trial. Keep the sequence. Once you've generated a sequence of randomization sequence, keep that concealed so nobody can predict the next allocation. Use envelopes that you can't see through so that you can keep it hidden, or on a computer don't reveal it to anyone. There's a great video here that illustrates with beads and stones how blocked randomization and stratified randomization works. This is worth looking at. We want to blind participants when possible from allocation. It's useful if participants don't know whether or not they're in the treatment arm or the comparator arm. Prototypically, this has been done with placebo control approach. So they can't tell, patients can't tell if they're getting an active pill or a sugar pill. Why is that an issue? Well, if you know which allocation you belong to, it might lead to something known as performance bias. That is, you behave differently because you know that you're in the treatment arm, for instance. It has to do with a lot of different factors, but some of it has to do with participants in a study living up to the expectations of them. If you know that you're receiving an app for physical activity that's supposed to increase your physical activity, you might increase your physical activity because you know that you're in the treatment arm. You're getting something novel. Sometimes it's impossible to blind participants, or even unethical. Sham surgery, for instance, just opening people up and closing them again would be sort of unethical, just in order to hide treatments. And even if you did something like that, even when you're blinded, there's multiple ways that this can be compromised. Unwanted side effects. If you are experiencing one of the side effects that you knew going into the study could happen, it's going to be pretty obvious that you are in the treatment arm. But also wanted effects, sort of you're actually improving in a way that you didn't expect, then you also believe then that you're in the treatment arm. Another key thing is, when it comes to behavioral interventions at least, is that if participants know that they're getting a treatment and they like it, they like the treatment and they want others to also receive it, they might know that depending on how the trial turns out, other people will receive treatment. And so they might lie or sort of bias their outcomes to more positive than they should have been, just because they want the trial to be successful. Okay, so blinding has a lot of consequences, more than the ones I've listed here. Blinding personnel from allocation is equally important. Blinding researchers and staff helps them avoiding differently and behaving differently around patients. It helps them to not actually disclose to participants which group they belong to. So if you blinded participants but didn't blind the research personnel, they might actually accidentally disclose which group they belong to. Blinding the person who's doing the data analysis could also be important, so that the data analysis isn't affected by knowing which group people belong to. There's an interesting paper here worth having a look through. It's a systematic review comparing blinded and non-blinded outcome assessors. So they've had individuals who've perhaps called participants in a study and asked them about self-reported outcomes. And they've had individuals who were blinded and individuals who were not blinded to allocation when they called. And it turns out that odds ratios were exaggerated by 36% among the non-blinded assessors. And while this was compatible with a high rate of agreement between blinded and non-blinded outcome assessors, it was driven by misclassification of a few patients. It's worth looking into, and it's interesting how you really can get a number here showing that this does affect outcome assessment quite a lot if the personnel are blinded or not. So the last thing I want to look at when it comes to the preliminaries in randomized controlled trials is deception. Using deception should be used with caution, but sometimes we need to deliberately hide information from participants. In this study, the effect of question order and outcomes in the core outcome set for brief alcohol interventions among online help seekers, the idea was to see how people respond differently to questions depending on which order the questions were asked. So if I first ask you about your alcohol consumption and then about problems with your alcohol consumption, problems that you might have experienced, do you respond differently than if I reverse the order? If we told participants about this, that this was the nature of the study, then probably those effects would have disappeared. And so in this study, we basically just asked participants to respond to a survey, and unknowingly they were randomized to different orders of the survey. Another type of deception is to not tell participants at all that they're part of a trial. It's obviously controversial and should be used sparingly. But a few years back, we did a study like that. This was an attempt to estimate effects of a brief alcohol intervention, which consists of just assessment and feedback, which we believe then to be able to get as close as possible to the true effects of such an intervention in a big population, we had to remove the fact that people or participants were aware that they were in a trial. And so what we did was we got email addresses of university students and we randomized them into 3 groups. The first group got an email with a link to a questionnaire or an assessment, and once they've assessed themselves, they got feedback and advice for change. The second group got a similar email with a link, but they were only given the assessment and no feedback or no advice. And the third group were not contacted. None of these individuals were told that they were part of a study. So any effect of knowing that you're part of a study was removed, or at least that was our attempt, that we wanted to remove them. 3 months later, all students got an email with an invitation to take part of a lifestyle survey. It was framed as, we didn't mention that, 3 months ago you responded to questions about alcohol, now we would like to follow up. It was just framed as a completely different survey and not connected at all to the questions about alcohol that you might or might not have answered before. What we found here was, well, there's a lot of results and I won't go into them, but interesting things that come from this is that we found that assessment, just being assessed without any advice at all, seemed to have an effect on alcohol consumption when we compared to the individuals who had not been contacted. This type of very naturalistic study to really get to understanding what the effects are of an intervention in a true setting or a real world setting, removing any effects of actually being part of a trial, are rare for good reasons, because there are ethical considerations when doing it like this. At the time, it was considered ethically defensible because we knew very little about the effects of trial participation for these type of interventions. You can read more about the study and all the findings here in the link.